Hello everyone, I'm Dr. Prajnavi Karki, Junior Resident in the Department of Clinical Immunology and Rheumatology at St. John's Medical College Hospital, Bangalore. Today, I'll be narrating an interesting short case titled A Dance to the Autoimmune Tune. This 25-year-old male, previously diagnosed with systemic lupus erythematosus and class 4 lupus nephritis, presented to our OPD with involuntary movements of the right side of his body. These movements were subacute in onset, brief, spontaneous, and involuntary that primarily involved the distal parts of his right upper limb, classically termed as the milkmaid's grip. It also involved similar movements in his right foot and twitching of his right-sided facial muscles. However, there was no history suggestive of prior focal neurological deficits or cranial neuropathy, and mini-mental scale examination was normal. His baseline investigations include a normal routine investigation panel, a strongly positive anti-nuclear antibody, a positive anti-double-stranded DNA, and a positive APLA workup with marginally elevated anti-cardiolipin antibody IgG. Additionally, complements were decreased and kidney biopsy showed class 4 lupus nephritis with mesangial and peripheral deposits of IgG and C1q. After considering the various differentials of chorea, an MRI of the brain and an MR venogram were performed that were normal. Additionally, C3, C4 and other routine investigations were also within normal limits. So based on the clinical history, physical examination, histopath and radiological investigations, a diagnosis of systemic lupus erythematosus and class 4 lupus nephritis with immune-mediated hemichorea was established. Prior to the onset of chorea, he was on treatment with steroids, mycophenolate mofetil, and hydroxychloroquine. The steroids were escalated and mycophenolate mofetil was optimized. As the symptoms interfered with his daily activities and work, a low dose of aspirin and trihexyphenidyl were also added. In this presentation, we focus on why chorea occurs in lupus. Chorea is an uncommon manifestation of lupus and its pathology still remains unclear. Two hypotheses have been proposed. The first is the presence of antiphospholipid antibodies and the occurrence of chorea in lupus. Antiphospholipid antibodies cross-react with other phospholipids that lead to direct antibody-mediated damage to the phospholipid-containing areas of the basal ganglia. The second is the vascular hypothesis, that is, the occurrence of a few thrombotic events that lead to reversible ischemia in the basal ganglia microvasculature. A few take-home points include neuropsychiatric SLE occurs in 10 to 60% of lupus in the course of illness, among which movement disorders account to less than 5% and chorea 1 to 2% and even 9% in childhood, making it a very rare manifestation of lupus. Although chorea usually occurs during the course of SLE, it may also be the presenting manifestation of the illness. In one of the largest case series, including 32 patients with chorea, 11 had chorea as the presenting manifestation of lupus. The occurrence of chorea in lupus has found to be associated with the presence of antiphospholipid antibodies. A number of studies indicate immunoglobulin IgG anticardiolipin antibody as the main antibody related to lupus chorea, as we can see in our patient. To conclude, lupus rarely manifests with movement disorders like chorioathetosis, and antiphospholipid antibodies are often found in such patients. Therefore, while considering the various differentials of chorea, SLE must not be overlooked. Thank you.